From Microbe TV, this is Infectious Disease Puscast, episode 40, recorded on October 25th, 2023. I'm Daniel Griffin, and joining me today is Sara Dong.
Hello, everyone. I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. I have to start by giving a shout out to Priya and the ID Week episode. She did an awesome job.
She did. Thank you, Priya. It was great to have her. I don't know if our listeners know, but she was a mentee of mine. I was her one of her attendings when she was going through the fellowship at Columbia. So it's great to see her again.
Yeah. All right. Well, Puscast is a review of the ID literature from the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. We're going to jump right into viral, and remember to listen to This Week in Virology. So I will start off with an article that I thought you were going to grab there, Sara, so I stole it from you. But the article, Sustained Viral Suppression with Dolutegravir Monotherapy over 192 weeks in patients starting combination antiretroviral therapy during primary human immunodeficiency virus infection, early simplified, a randomized controlled multi-site non-inferiority trial. Recently published, and there's even a nice editorial commentary, dolutegravir monotherapy, possibly boosted by highly active natural immunity and CID. So these are the results of early simplified, a randomized open label non-inferiority trial where people living with HIV who started ART less than 180 days, right? So these, I want to point out, there's a couple really important things here. So don't try this at home unless you are paying attention. So they have to start on ART less than 180 days after a documented primary HIV infection with suppressed viral load, right? So you need both of those. And then they're randomized 2-to-1 to the dolutegravir monotherapy, 50 milligrams daily, or continuation of their ART. And the primary endpoints were the margin of people living with HIV with viral failure at 48, 96, 144, and 192 weeks. After 96 weeks, randomization was lifted. Patients could switch around. Now, this caught me, right? It seems to violate all those rules that I learned about treating HIV, all those rules about multi-drug regimens to avoid developing resistance. Well, what did they find? Of 101 people living with HIV randomized, 68 were assigned to dolutegravir, 33 to the standard ART. Basically, no virological failure occurred in either group during, as they say, 13,308 and 4,897 person weeks of follow-up for the two different groups out to week 192. So this all sounds great, but let us look at the editorial commentary. Here we read, dolutegravir monotherapy should be strictly avoided. Pause. 3 randomized clinical trials conducted in Europe, DOMO, DOLAM, and MONK studies on the efficacy of maintenance dolutegravir monotherapy have consistently failed after the initial 24 weeks. Over time, the risk of virological failure increased significantly when compared with triple therapy. It is noteworthy that emerging resistant mutations are often observed during HIV RNA replication, despite the so-called high genetic barrier associated with dolutegravir, which may compromise use of antivirals in this class. Given the proven effectiveness and safety of dual therapy comprising dolutegravir and lamivudine, prescribing lamivudine-sparing dolutegravir monotherapy today would be an erroneous decision. But wait, what about this study? In the commentary we read, we propose that the distinctiveness lies in the highly selective population under study. All participants were treated either during the acute phase or at least very early in their infection, and this treatment was continued for a median of 3.6 years before switching to monotherapy. Early and prolonged antiretroviral treatment initiated during the primary infection ensures enhanced immunological restoration, greater reduction in viral reservoirs, and better restoration of the anatomical structures of the gut-associated lymphoid tissue. The benefits of prolonged treatment initiated during primary infection are such that a small proportion, at least 5% of people with HIV treated in this manner may even achieve control over HIV replication after treatment interruption. So I want to hit those points. These are people for whom they were started on treatment early within the first 6 months, and they had been treated for almost 4 years before you switch over. So just sort of keep this in that context. Got that? Got that, Sarah? Okay.
Got it.
Now, the next article, Mpox neutralizing antibodies at 6 months from Mpox infection or MVA-BN vaccination, a comparative analysis published in the Lancet Infectious Disease. So here we read that people vaccinated with the MVA-BN, so that's Bavarian Nordic vaccine, were found to develop frequently low or medium Mpox neutralizing antibodies when compared with infected individuals. 1 in 10 vaccinated individuals showed no detectable neutralizing antibodies at 6 months, whereas every person with Mpox infection developed antibodies. So one more example of how the best way to not get an infection is to get an infection. Or perhaps why measuring just antibodies might be like a blind man feeling the tail of an elephant. Okay, sorry
Best
about
way
that.
to get those antibodies.
But they seem to be protected. I don't understand. Yes, you should listen to TWiV.
Yeah.
Okay, bacterial. Let's jump right into bacterial with, well, one of our favorite medicines out there. Linezolid, the article Linezolid population pharmacokinetic model in plasma and cerebral spinal fluid among patients with tuberculosis meningitis, recently published in JID. Now, this is clever. The investigators looked at 30 participants in the laser TBM. I thought you'd like that. Pharmacokinetic sub-study to get pharmacokinetics in the CSF for patients. The intervention groups received high-dose rifampicin plus linezolid for 28 days and reduced the rifampicin down to 600 per day. Plasma sampling was done on day 3, day 28. Lumbar CFS samples were obtained on both visits. They ended up with 247 plasma, 28 CSF observations, and the plasma pharmacokinetics were described by, you ready for this, 1 compartment model with first order absorption and saturable elimination. Rifampicin co-treatment duration did not affect linezolid pharmacokinetics, and the plasma CSF equilibrium half-life was 3.5 hours. So basically, right, deep breath, we are getting linezolid into the CSF at about 30% of plasma concentrations, and we reached a maximum value of 37%.
And since we were speaking about TB meningitis, I pulled this article from the New England Journal that some people may have seen, adjunctive dexamethasone for TB meningitis in HIV positive adults. So this found that among adults with HIV-associated TB meningitis, the addition of dexamethasone to their anti-TB regimen and ART did not reduce mortality during the 12 months of follow-up. So just a note on the design, it was a double-blind randomized placebo-controlled trial completed in Vietnam and Indonesia. 520 adults were assigned to either dexamethasone or placebo, along with, again, as I mentioned, the what they considered standard of care anti-TB therapy and ART. So patients who had grade 2 or 3 TB meningitis had 4 weeks of IV dexamethasone and then 4 weeks of oral steroids, and grade 1 disease received IV and PO treatment for 3 weeks each. And the primary endpoint was death from any cause during 12 months after randomization. So the percentage of participants who died during the follow-up did not differ between the dexamethasone group, so that rate was 44.1%, and the placebo group, 49%, and they had similar sort of safety adverse event profiles. I point out these are mostly relatively young HIV positive males. Most of them had grade 1 or 2 TB meningitis and a CD4 count under 100. So I think what first off is very shocking is the awful mortality rate in both groups of basically approximately half of the patients dying in that window. One thing that's interesting is about a quarter of the participants did receive open label glucocorticoids during the trial. So it likely reduces the ability to find differences between those groups. And of course, the setting and the patient population makes an impact here. These about a third of the participants were newly diagnosed HIV. half of the patients had not received ART. About half had a CD4 under 50. And then it sounded like there is some limited or minimal access to procedures like VP shunting for hydrocephalus, which certainly would impact how these patients do. So I'm curious what people will think. I think that there probably are still going to be a lot of people who find that steroids may have a chance of benefit, especially if you sort of look at this study, but also look back at the 2004 Thwaite study that's also a New England Journal, but found that patients who received dexamethasone did better because it's a relatively cheap drug. It doesn't seem like there's a chance of harm. So I don't know. I think a lot of people are going to have a hard time not providing steroids. But I guess we'll see what people think.
All right. So here we have the article Cefepime versus Piperacillin Tazobactam Zosyn in adults hospitalized with acute infection, the ACORN randomized clinical trial, and another editorial piece, acute kidney injury with empiric antibiotics for sepsis, published in JAMA. So we get this warning about the risk of acute kidney injury with co-administration of Zosyn and vancomycin. And after the stewardship people jump in, now every patient admitted gets cefepime vancomycin. I don't know if you're having that experience, Sarah. But
I'm usually, yeah. I've been at cefepime institutions for several years now.
now, is this a good thing or a bad thing? So here we have the results of the antibiotic choice on renal outcomes, ACORN. What do you think? Antibiotic choice on renal, it works.
I like the word because it's unique, although it doesn't tie into the story. So it's like 4. I will give it 4
Yeah,
stars.
because you would like something that, had Zosyn and Okay.
Yeah.
All right. So the ACORN randomized clinical trial where they compare cefepime versus piptazo in adults for whom a clinician initiated an order for anti-pseudomonal antibiotics within 12 hours of presentation to the hospital in the emergency department or medical intensive care unit at an academic medical center in the U.S., we won't mention which one, between November 10, 2021 and October 7, 2022. So the primary outcome was the highest stage of acute kidney injury or death by day 14, measured on a 5-level ordinal scale ranging from no acute injury to death. The 2 secondary outcomes were the incidence of major adverse kidney events at day 14, number of days alive, and free of delirium and coma within 14 days. There were 2,511 patients included in the primary analysis. 94.7% were enrolled in the emergency department. And here is a big one. You ready for this? 77.2% were receiving vancomycin at enrollment. All right, make sure everyone gets some vancomycin. The incidence of major adverse kidney events at day 14 did not differ between groups. 10.2% in the cefepime group, 8.8% in the Zosyn group. Actually, that's a 1.4% difference, trending in the wrong direction. Now it gets worse. Patients in the cefepime group experienced fewer days alive and free of delirium and coma within 14 days than those in the Zosyn group. And that was statistically significant, a 21% reduction. Ouch. I'm thinking you may want to switch over to a Zosyn institution. But anyway, among hospitalized adults in this randomized clinical trial, treatment with Zosyn, piperacillin, tazobactam did not increase the incidence of acute kidney injury or death. Treatment with cefepime resulted in more neurological dysfunction. So I'll leave a link into the editorial, so do read the short article if you can get through the full article. A big thing from my perspective is the last comment. Now the question of whether antibiotics with anti-pseudomonal activity are even required for community-acquired and low acuity sepsis can be addressed.
This next one I have is fairly quick. It's from MMWR. It's a notes from the field. Mycobacterium abscessus outbreak related to contaminated water among ventilator-dependent residents of a pediatric facility, Pennsylvania, 2022. This covers an outbreak of M. abscessus that was identified in late September and early October of 2022. It sounds like it actually was just 3 cases, 2 that were deemed colonizations and 1 clinical infection. But the investigation was detailed and suggested that the outbreak was related to substandard water quality and inadequate IPC practices. So the Pennsylvania Department of Health collected environmental samples from faucets, aerators, shower heads, drains, filtered water, and ice machines, as well as other care areas, and found mycobacterial species in 76% of the 21 samples. They think that there were areas of the building, it sounds like, that weren't being used that likely led to some stagnant water in the plumbing. And then there was also, it sounds like, a lack of a sort of water management program, meaning that the water quality wasn't monitored. So, I think all of us have cared for patients who spend time in facilities like this. In this case, it was a 34-bed pediatric residential facility. So patients, who are living there, but it's not really a dedicated healthcare facility. So just a good reminder of what these investigations look at, where mycobacteria can hide. Um, and I think just something to remember that sometimes these care settings can put patients at risk for different types of bugs, even if their underlying disease process maybe didn't uh, make you immediately think of it on your list.
Okay. All right. Well, this trial made sense, so I'm glad it was done. The trial of vancomycin and cefazolin as surgical prophylaxis in arthroplasty, recently published in New England Journal of Medicine. I always thought this made sense, right, Sarah? I know people that say, "Oh, a lot of MRSA. We're not covering for MRSA. We should throw a little vanco at people." Well, let's do some science. So these are the results of a multi-center, double-blind, superiority, placebo-controlled trial where they randomly assigned adult patients without known MRSA colonization. Why didn't they check that first? Anyway, okay, moving forward, who are undergoing arthroplasty to receive 1.5 grams of vancomycin or normal saline placebo. And why did they not check out at time? Anyway, in addition to the cefazolin prophylaxis, the primary outcome was surgical site infection within 90 days after surgery. So, all right, so we already know that vancomycin patients are going to have less infections, right? Well, let us see what they found. A total of 4,239 patients underwent randomization among 4,113 patients in the modified intent to treat population. Folks undergoing knee, hip, shoulder. Surgical site infections occurred in 4.5% in the vancomycin group and in only 3.5% in the placebo group, with a relative risk reduction of 1.28 by not getting vancomycin. Interesting. Well, did not reach statistical significance, so I think we're still okay. Let's look at subgroups among patients undergoing knee. 5.7 in vanco, 3.7 in placebo, relative risk 1.52. Okay, well, what about hips? In the hips, 3% in the vanco, 3.1% in the placebo. Okay, that's going in the right direction. Yeah, not really. The addition of vancomycin to cefazolin prophylaxis was not superior to placebo for the prevention of surgical site infections in arthroplasty among patients without known MRSA colonization. And I wonder if it would be helpful if they had MRSA colonization.
Excellent. In clinical microbiology and infection, I pulled a paper, trimethoprim sulfamethoxazole significantly reduces the risk of nocardiosis in solid organ transplant recipients, systematic review, and individual patient data meta-analysis. And I actually couldn't remember if this had come up on Puscast before. I know we've talked about it a time or two on Febrile, but as many people know, whether trim-sulfa prophylaxis actually prevents nocardial infection in transplant patients is fairly controversial. The authors wanted to determine, and this is their list, the effect of trim-sulfa in prevention of nocardiosis, its dose-response relationship, its effect on preventing disseminated nocardiosis, and the risk of trim-sulfa resistance in cases of breakthrough infection. So this had a combination of things. They did a systematic review of 13 studies, and then they took a look at individual data from 3 available case control studies, which worked out to 260 solid organ transplant recipients with nocardia and 519 uninfected controls. They did find that trim-sulfa prophylaxis was independently associated with significantly decreased risk of nocardiosis, an adjusted odds ratio of 0.3, a 95% confidence interval of 0.18 to 0.52 with moderate certainty of evidence. The authors did not find a specific dosage of trimethoprim sulfa that was considered protective. They found that variables independently associated with an increased risk of infection included older age, current use of steroids, high calcineurin inhibitor concentrations, recent acute rejection, lower lymphocyte count, heart transplant. So things I think that are not um, too surprising. They did comment on the breakthrough infections. So 25% of the 260 infections were breakthrough. They were generally susceptible to trimethoprim sulfa, so 90%. And it didn't seem like there was any specific relationship between specific nocardia species for the breakthrough infections. So, all in all, I'm not really sure this helped me answer a new question. I think we kind of knew that trim sulfa that's used for PJP prophylaxis seems to reduce the rate of nocardial infections, that there were breakthroughs that retain trim sulfa susceptibility, and the study was not able to answer the big question of what dosing to use. So, can we use intermittent dosing where you get 2 to 3 times a week rather than daily? What is a sufficient amount of drug to prevent nocardial infection? And honestly, at the end of the day, prophylaxis can't exclude nocardia from the differential in these patients. So, always have to keep that in mind.
All right. Well, perhaps someone can write in and explain this to me. Maybe steal
I'm glad
some
you picked
ideas,
this one.
Sarah. But the article, Risk of Hematological Cancers Among Individuals Tested for Borrelia Burgdorferi Antibodies and Borrelia Burgdorferi Seropositive Individuals, a nationwide population-based matched cohort study published in CMI. So here the authors identify all the Borrelia Burgdorferi seropositive individuals in Denmark, 1993 to 2020. We've got 52,200. And they constructed 2 age and sex matched comparison cohorts. They calculated short-term odds ratios and long-term hazard ratios adjusted for age and sex. They found that compared with the background population, individuals tested for Borrelia burgdorferi antibodies had increased short-term and long-term risk of hematological cancers.
I don't really know what to do.
Yeah.
From the Journal of Antimicrobial Chemotherapy, I recommend folks bookmark this paper. It's in vitro susceptibility patterns for slowly growing non-tuberculous mycobacteria, or NTM, in the US from 2018 to 2022. So this resource has aggregated susceptibility patterns from isolates sent to National Jewish from the years that I mentioned. 80% were MAC or Mycobacterium avium. Most of those samples were sputum, which is not too surprising. And just to give a snippet for MAC, 94 to 100% of isolates were clarithromycin, sorry. 64 to 91% were amikacin susceptible. 2 to 31% were linazolid susceptible, and 4 to 41% were moxifloxacin susceptible. So there's actually a really awesome antibiogram in figure 2 that is, of course, color-coded, but I realized I should have written it down. There was, I think, a prior publication a couple months ago for rapid grower NTMs, that I believe was in a different journal, but was a similar sort of antibiogram for NTM. So a really nice resource that you can refer to when it comes up with your specific patient.
I love all the colors. And I was going to say, Sarah, if people are listening, they probably know what clarithro means. We probably
I know.
Really nerdy, specialized crowd.
I know.
So, all right.
It's and I was trying to make sure with trim sulfa, I was like, I could say Bactrim, but I refuse.
Okay. All right. Fungal, I'm waiting patiently for the next season of The Last of Us. But in the meantime, we have the article, Real World Use of Mold-Active Triazole Prophylaxis in the Prevention of Invasive Fungal Disease, results from a subgroup analysis of a multi-center national registry published in Open Forum Infectious Disease. So, results of a subgroup analysis of a multi-center observational prospective registry in the United States from March 2017 to April 2020, where they included patients who received MATs, mold-active triazoles. Sure, people we'll start using that 3-letter acronym in the future. Order some mats for this patient. What were those mats? Izavuconazole, posaconazole, voriconazole. The primary objective was to describe patient characteristics and patterns of mat use. Exploratory analysis included the frequency of breakthrough and mat-related adverse drug reactions. Invasive fungal disease, IFDs, the TLAs here are killing me. They report that breakthrough IFDs, invasive fungal diseases, were uncommon in patients who received MAT prophylaxis, mold active triazole prophylaxis. Candida and Aspergillus species were the most commonly reported breakthrough pathogens when it happened, and the discontinuation of the mats due to adverse drug reactions was infrequent. So they conclude by saying the findings support prophylactic strategies with izavuconazole, posaconazole, and voriconazole in high-risk patients. And hematological malignancy was the most frequent underlying condition in the prophylaxis subgroup, 76.5%. Now, this one is maybe interesting, actually. So the article, Fungal Microbiota Sustains Lasting Immune Activation of Neutrophils and Their Progenitors in Severe COVID-19, published in Nature Immunology. So here we read that the investigators found elevated levels of Candida albicans IgG antibodies in patients with severe COVID-19 who had intestinal Candida overgrowth, mycobiota dysbiosis, I like that, myco, and systemic neutrophilia. They suggest that gut fungal pathobionts may contribute to immune activation during inflammatory diseases, offering potent mycobiota immune therapeutic strategies for COVID-19 with prolonged symptoms. All right, so more stuff to look at in the long COVID realm. Parasitic, be sure to listen to This Week in Parasitism. We just recorded an episode at ASTM&H, which used to be my favorite meeting until I just got COVID at it. But other than that, moving on, the article Real-Time Dermoscopy of Numerous Mites Crawling on the Crusted Scabies was published in CMI. Dermoscopy, what is that? Well, let's get into it. A 17-year-old man with Down syndrome presented with a 6-month history. Oh my gosh, when did they diagnose this poor man? Of extensive, scaly, crusty, pruritic rash. The eruption developed during his hospitalization for Down syndrome. He's in a hospital. Where are the doctors? In a local psychiatric hospital. Oh, now I know. 6 months ago, and progressively aggravated despite, can you imagine this, despite topical application of steroids and Chinese herbs. I don't understand why they aren't going to kill the mites. They include a nice dermoscopy image. And right, dermoscopy revealed numerous brown triangular structures and trailing burrows. The delta wing jet sign. Good news here, as the patient was treated with 5% permethrin lotion daily for 1 week, and then twice weekly for 2 weeks, and oral ivermectin twice weekly for 3 weeks after occlusive dressing with urea ointment and mechanical debulking of crusted plaques. So, Sarah, I don't know if you've ever used a dermoscope, but it actually allows you to see the female mites burrowing through.
That's fascinating. Although, like, looking at these pictures, if he really had this for 6 months, and you would have thought that this diagnosis would have at least sort of been thought about before.
Were you going to say
because it's pretty
would
advanced.
have jumped out at you, and you picture the mite jumping out at you? Just that was my pun there.
Oh, yeah, those pictures are really.
I wasn't sure the dermoscopy images were so great. Like I've seen these under a dermoscope, and I take one often with me when I travel tropically. And actually, I keep it in the car and bring it into the hospital every so often because, yes, that happens here too.
Yeah.
All right, so I just want to highlight that there was a review, The African Eyeworm, Current Understanding of the Epidemiology, Clinical Disease, and Treatment of Loiasis, published in the Lancet Infectious Diseases. And they point out, although adult worm migration seems most closely linked to symptomatic disease, high levels of microfilaremia are associated with clinically important complications and death. And the amount of disability and even death are significant. So I will put this in the worth reading. All right, we're moving into our last section, Miscellaneous, the article Decolonization in Nursing Homes to Prevent Infection and Hospitalization was published in the New England Journal of Medicine. So, for background, nursing home residents are at high risk for infection, hospitalization, and colonization with multi drug resistant organisms. So, this study here is why they have the word hygiene in organizations like ASTM and H. We have the results of a cluster randomized trial of universal decolonization as compared with routine care bathing in nursing homes. The trial included an 18-month baseline period and an 18-month intervention period. So the decolonization entailed the use of chlorhexidine for all routine bathing and showering and administration of nasal povidone iodine twice weekly for the first 5 days after admission, and then twice daily for 5 days every other week. The primary outcome was transfer to a hospital due to infection. The secondary outcome was transfer to a hospital for any reason. An intent to treat as a sign difference in differences analysis was performed for each outcome with the use of generalized linear mixed models. All right. In this study, in nursing homes, universal decolonization with chlorhexidine and nasal iodophor led to a significantly lower risk of transfer to a hospital due to infection than routine care, and the number needed to wash was 9.7 to prevent one infection-related hospitalization and only 8.9 to prevent one hospitalization for any reason. So apparently cleanliness is next to staying out of the hospital.
Love it. And I realized, I'm sorry, I didn't have any fungal papers, which is surprising. I think it's because I had too many mycobacterial papers. I pulled this one from CID. Can chatbot artificial intelligence replace ID physicians in the management of bloodstream infections? A prospective cohort study.
Why are they doing this, Sarah? Why are they trying to replace it with chatbots?
Well, this one was in Paris. So at this hospital in France, every patient with a positive blood culture, it sounds like routinely gets an evaluation by an ID doc. So they make a management plan, they get a reassessment within the next couple of days. So in this study, they basically plugged in a report with the patient info and instructions to suggest a management plan. And then a team of 2 senior ID physicians compared the human consultant plan with the chat GPT plan. And they had a couple different classifications. So there was appropriate for the plan if it was identical to the consultant, not specific enough, inadequate, and harmful if something important like source control wasn't addressed. And then they noted the antibiotics as appropriate and optimal, appropriate, non-optimal, inadequate, and then inadequate and harmful, and so on. There were 45 cases, and this pilot study found that AI had identical diagnoses in 59%. They had satisfactory workups in 80% of cases, and the empiric antibiotics were considered adequate in about 2/3, so 64%, and then harmful in 1 case. The source control plans were inadequate in 9% of the cases. But actually, the definitive antibiotic therapy was only optimal in 36% and harmful in 5%. And then sort of the overall management plan was optimal in only 1 patient, satisfactory in 39%, and harmful in 16%. So their conclusions: use of Chat GPT for first positive blood culture episode were considered optimal in 2%, satisfactory in 39%, and harmful in 16%. So suggesting that I guess we have our jobs for a little bit longer.
Well, I hate to say so. I feel like it's rigged because we asked the people what they thought. Now, if we ask Chat GPT and we do it the other way, what would Chat GPT think of our management?
Yeah, and it's fascinating because I think people are still learning, like, how do you plug in and like prompt these AIs, and like it, obviously comes back to the information that gets put on. But still, I'd like to, support things that suggest that us human ID doctors are still in business.
All right. Well, I think I'm on a theme, which is the theme of washing people. And this is the article, Nasal Iodophor Antiseptic versus Nasal Mupirocin Antibiotic in the setting of chlorhexidine bathing to prevent infections in adult ICUs. So how are we going to clean out a randomized clinical trial published in JAMA? These are the results of a two-group, non-inferiority, pragmatic, cluster randomized trial conducted in U.S. community hospitals, all of which used mupirocin for universal decolonization in ICUs at baseline. They're going to go ahead and they're going to randomize 137 randomized hospitals. Ultimately, there were 801,668 admissions in 233 ICUs, lots of hazard ratios, but just to pull it together, they found that nasal iodophor antiseptic did not meet criteria to be considered non-inferior to nasal mupirocin antibiotic for the outcome of Staph aureus clinical cultures in adult ICU patients in the context of daily CHG chlorhexidine bathing. And so maybe worse for iodophor. So really coming out on the side of nasal mupirocin. And this is my last one. Just last week, the FDA approved Pembrea, the first and only vaccine for the prevention of the 5 most common serogroups causing meningococcal disease in adolescents. Currently, we have one shot for type B, another shot for the other serotypes. So here, based on phase 3 trial, this one shot appears to be just as good at getting the 2 other shots and protect against the 5 most common serotypes. Do you know, apparently today at some point, the ACIP, the CDC ACIP met, and we will find out whether or not this is going to be recommended.
I saw that it was going to be talked about, but I don't know what the results were. It's exciting.
Should I check really quick? Let's check really quick while we're on the air. Hold on.
Love it.
Stay there. Let's see. And ACIP, I'm checking right now in real, well, it's not real time because it's going to be recorded by the time this will be
Relative real time.
CDC okays recommendations. Yes, real time. CDC
Cool.
committee okays recommendations for pentavalent meningococcal mpox and also mpox vaccines. So they did a lot today. So they debated stuff, and yes, they did vote 10-4 in favor of allowing the use of the pentavalent vaccine. So, all right, thumbs up. We got that.
Nice. Well, that brings us to a very exciting end to this podcast. Breaking news. As always, the references for this show are available at microbe.tv, the home of our multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts, microbe.tv/Puscast, and on your favorite podcatcher. We love to get your questions, comments, and paper suggestions. Send them to puscast@microbe.tv. And if you like what we do, or even if you don't, consider supporting the science shows of Microbe TV at microbe.tv/contribute or Parasites Without Borders and click on the convenient donate button.
I'm Sara Dong. You can find me at swindong, at Febrile Podcast, or at febrilepodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com. I'm also on Twitter, as well as the other podcasts, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another podcast is infectious.